مساء الخير على حضراتكم. بنشكر الاستاذ الدكتور اشرف طلعت على الاليجنت برزنتيشن، وهي كانت محاضره واضحه ما جالناش اي اسئله عليها، وبالتالي هننتقل على السيشن الجايه، سيشن اندوكراين، وان شاء الله يبقى ختامه مسك. معانا الاستاذ الدكتوره علياء الاجوني هتقدم لنا السيشن اللي جايه ان شاء الله.
مساء الخير على حضراتكم جميعا. بذكر الزميل العزيز الدكتور علاء عبد السلام على الدعوه الكريمه، ولي الشرف ان انا مع حضراتكم النهارده في سيشن الاندوكراين. في عندنا 3 eminent سبيكرز. نبدا باول سبيكر بروفيسور رشا طريف، عين شمس يونيفرسيتي. طبعا بروفيسور رشا one of the eminent speakers، محاضراتها بتبقى ذات قيمه to the points وكلنا بنستفيد منها. هي هتتكلم عن موضوع very important اللي هو delayed puberty in males، مشكله من المشاكل اللي بنشوفها. واتفضلي يا دكتوره رشا، بنرحب بحضرتك.
بسم الله الرحمن الرحيم. بشكر الأستاذ الدكتور علاء عبد السلام على دعوتي. مبسوطة جدا بوجودي مع حضراتكم، سعدت وتشرفت. هتكلم عن توبيك الحقيقة ابتدى يبقى common، بنشوفه كتير، اللي هو الميل هايبوجوناديزم أو delayed puberty in males. والسؤال المهم اللي هحاول أجاوب عليه is it pathological or simple delay. Let me open the scene by a quite common scenario. A worried parent of an adolescent boy having a lot of questions in mind. When facing an adolescent with hypogonadism, the frequently asked questions by the parents are: does my boy have delayed puberty? Will it affect his final height? Could it be hiding a serious medical illness? And finally, does he need treatment or not? And there are some decisions that need to be taken by the pediatrician. First and most important, the thread between simple and pathological delayed puberty. When to refer to a pediatric endocrinologist, and finally, to treat or not to treat. Simply, what triggers the onset of puberty? Simply speaking, there is a release of the CNS inhibitory effect on the hypothalamo-pituitary gonadal axis. In the pre-pubertal period, there is a lock on the HPG axis, and with the onset of puberty, there is unlocking of the CNS inhibitory effect from the axis. And the question here, who presses the start button? The answer is kisspeptin. Kisspeptin presses the start button. It's a peptide expressed in the hypothalamic nuclei, and it was named after the chocolate kisses made famous in the city where it was discovered. Kisspeptin binds to KIS1 receptor, triggering G protein signaling cascade, which stimulates GnRH production, triggering the onset of puberty. So in the prepubertal period, there is a strong central inhibition on the kisspeptin, which inhibits GnRH neuron. With the onset of puberty, release of the CNS inhibition stimulates kisspeptin neuron, ending by GnRH stimulation neuron, starting the onset of puberty. The question here, how does this happen? Looking at the hypothalamo-pituitary gonadal axis, prior to the onset of puberty, as previously mentioned, there is a neuronal inhibition on the axis. And the sex steroids, namely testosterone in boys, exerts a negative feedback at the level of anterior pituitary and hypothalamus. The hypothalamic gonadostat and pituitary are very sensitive to the negative feedback from the sex steroid. Now, with the onset of puberty, the sensitivity of hypothalamus and pituitary to the negative feedback by the sex steroid decreases with time, until there is a total release of the CNS inhibition. And here, there is stimulation of the GnRH, stimulating FSH and LH, and finally ending by stimulation of the axis and triggering the onset of puberty. Now, sex steroids and kisspeptin have got a dual relation, meaning that in the pre-pubertal period, as we said, the sex steroids exert a feedback negative suppression of the sex steroid. But with the onset of puberty, this is released and the sex steroid start to stimulate the kisspeptin, and therefore they stimulate the onset of puberty. So it's a bilateral or a dual mechanism according to whether it is prepubertal or pubertal. Now, kisspeptin does not work alone. It works hand in hand with other neurons, and the most eminent is the KINDY neurons, which work hand in hand with the kisspeptin to stimulate the GnRH neuron pulses, either directly via the kisspeptin or GnRH neuron stimulation, triggering the onset of puberty. So, KINDY neurons trigger kisspeptin and GnRH pulses. Here you can see it stimulates the GnRH neuron either directly or through the kisspeptin, ending by the pubertal onset. Looking even more, the neuromechanism here is that the KINDY neurons release neurokinin B, which binds to NK3 receptor, causing a calcium influx, increase in the intracellular calcium, stimulating pulses of kisspeptin, and therefore we will have GnRH pulses triggering the pubertal onset. So this is a very delicate micro mechanism ending by the pubertal onset. There are a lot of factors affecting the pubertal onset and the action of the kisspeptin neuron. The leptin and the IGF-1 have got a stimulatory effect on the kisspeptin, while ghrelin has got an inhibitory effect, and as we said, the sex steroid have got a dual mechanism, either inhibitory in the prepubertal period or stimulatory with the onset of puberty. As you see, this diagram shows you that there are a lot of genes being involved in the regulation of hypothalamo-pituitary gonadal axis, starting by KISS genes, kisspeptin, GnRH, pituitary development genes like HESX1, SOXX2, GnRH, CAL1 involved in Kalman syndrome, SF1, DAX1, FSH, LH, and a lot of numerous genes in addition to leptin being involved in initiation of puberty. This takes us to a very important question: which genes to study when we have a pubertal disorder? A very long list is to be mentioned, either genes regulating GnRH neuron migration or GnRH synthesis and release, or GnRH action, and finally those involved in gonadotropin synthesis. And these are the genes involved in the pathogenesis of either central precocious puberty or delayed puberty, according to whether we have inactivating or an activating mutation. Looking at the hypothalamo-pituitary gonadal axis in boys, we all know that the hypothalamus produces GnRH, stimulating antipituitary to produce FSH and LH. The LH stimulates the Leydig cells to produce testosterone, which is important for initiation and maintenance of puberty, as well as spermatogenesis, while FSH stimulates Sertoli cell to support in the spermatogenesis and to produce inhibin, which exerts a negative feedback at the level of antipituitary. In addition, testosterone by itself exerts a feedback mechanism at the level of antipituitary and hypothalamus as well to avoid oversecretion. Now, this diagram shows you the progress in the testicular size, starting in infancy, 1 to 2 ml size, increasing gradually till reaching the adult size of 25 ml. But I need you to remember this very important number, 4 ml. When the testicular size reaches 4 ml, this is coincident with the pubertal onset, which in turn is coincident with a rise in the FSH, LH, testosterone, and a drop in the AMH. Remember number 4. And this is the Prader archidometer that we as pediatric endocrinologists use it frequently for assessment of pubertal status of boys. Again, remember number 4. If the testicular size reaches 4, you're dealing with the onset of puberty. Looking at the progression of puberty in boys, usually it starts on an average of 11.5 by increase in testicular size, and then 12.25 increased genital size, pubic hair at 12.5, 14, which is the growth spurt. A lot of factors affect the onset of puberty, starting by genetics, nutrition, general health, exercise, climate, and finally, psychological factors. And this takes us to a very important question. Does delayed puberty affect the height of adolescence? Yes. The answer is a very big yes. Indeed, delayed puberty has got an effect on the height of adolescence, simply because there is synergistic effect of sex steroids working with growth hormone at the time of puberty to initiate the growth spurt. And please remember that the growth spurt constitutes around 50% of the total height. So adolescents who have delayed puberty will be shorter than their peers and will appear shorter finally if not properly treated. And this is to show you the adolescent growth spurt. Again, synergistic effect of sex steroids and growth hormone. Remember that the growth spurt in girls occurs 2 years earlier than boys, and that's why girls appear taller when they are at the same chronological age. Beard. Shaving the beard. Boys are so happy when they start to have the facial hair, but unfortunately, this is coincident with deceleration of the height. They won't gain more than 5 centimeters when the facial hair appears. Now, going to male delayed puberty. Male delayed puberty is defined as lack of testicular enlargement by the age of 14 in boys. And another important definition is the pubertal arrest, more than 5 years between the first and the last sign of puberty. Male hypogonadism is classified into 3 broad categories. First and most important, constitutional delay in growth and puberty, hypo or hypergonadotropic hypogonadism. These 2 causes, hypo and hyper, are pathological causes which need treatment, while constitutional delay in growth and puberty is a physiological condition, and by far it is the most common cause of delayed puberty that should be excluded from the beginning. Now, looking at the pathogenesis of delayed puberty, starting by hypogonadotropic hypogonadism. From its name, the whole axis is very low. Low GnRH pulses causing low FSH and LH, ending by low sex steroid. What about the hypergonadotropic hypogonadism? The problem will start from the gonads, the testes, secreting low sex steroid, causing high FSH and LH. So, if you have a case of delayed puberty with low FSH and LH, this is hypogonadotropic hypogonadism. If high FSH and LH, this is hypergonadotropic hypogonadism, and in both conditions you're going to have a very low testosterone. So the differentiating point to diagnose the type of delayed puberty is by gonadotropins and not by testosterone. You're going to find a very long list of causes for hypogonadotropic hypogonadism in boys, either congenital or acquired. The congenital is either isolated gonadotropin deficiency, whether it's idiopathic or Kalman syndrome. It could be due to panhypopituitarism or genetic mutation in pituitary transcription factor DAX1, septo-optic dysplasia, or others. The acquired causes are either due to tumors, trauma, irradiation, chronic illness, malnutrition, endocrine, or drugs, which could be excluded as well. The hypergonadotropic hypogonadism, as we said, the problem is in the testis itself. Always remember Klinefelter syndrome. It's not uncommon, it's there. Or could be primary testicular failure due to anorexia, cryptorchidism, chemo, radiotherapy, or Noonan syndrome. Now, how shall we think right when facing a boy with delayed puberty? First, ask yourself, is puberty totally absent or started and then arrested, meaning that this is a secondary cause? Exclude drugs, surgery, irradiation, chronic illness, malnutrition, and look for syndromic features. Assess the smell for Kalman syndrome, measure weight, height, and plot them on the growth charts. Do a proper Tanner staging and look for gynecomastia. And then we go for investigations. It's very important to do a bone age, which will be delayed in most of the causes. Electrolytes, liver, kidney functions, prolactin, thyroid functions, pituitary hormone, and the gold standard test, the GnRH stimulation test that we use for diagnosis of any pubertal problem, whether delayed or precocious puberty. Now, these are the diagnostic lab cutoffs indicative for the onset of puberty published in New England Journal of Medicine. If you have a basal LH of more than 0.3 or stimulated LH more than 5 or a morning basal testosterone at 8 a.m. more than 1.6, this indicates the onset of puberty. And sometimes you can find these labs even before the signs of puberty are clinically apparent. Now, based on the GnRH stimulation test, which way shall we go? When you have a case of delayed puberty, start by the GnRH stimulation test. Either you will have high FSH and LH or low FSH and LH. Remember to do a karyotype in any case of hypergonadotropic hypogonadism to exclude Klinefelter. And then, if excluded, it's primary testicular failure. If you have low FSH and LH, assess height and growth. If you have late onset secondary growth failure, always do a cranial MRI to exclude a CNS tumor. If normal, it could be due to chronic illness, malnutrition, or endocrine disease. If you have normal and then absent growth spurt, assess the smell to exclude Kalman syndrome. If normal, it's isolated gonadotropin deficiency, which could be proved, of course, by genetic testing. If you have a short boy with delayed bone age, which is exactly equal to the height age, then this is constitutional delay in growth and puberty. By far, again and again, this is the most common case that you should look for before jumping to other diagnoses. Now, the difficult question, is it transient or permanent hypogonadism? Again, the thread between simple delay and pathological delayed puberty. And based on that, shall we treat or not to treat? Again, these are the cutoffs to differentiate the transient from permanent hypogonadism published in New England Journal of Medicine. For random LH and FSH, if you have LH less than 0.1, FSH less than 0.2, this is permanent. If the LH is more than 0.5 and the FSH more than 0.9, this is temporary. And if the FSH is more than 10, is more than 12 and the LH is more than 10, then you have hypergonadotropic hypogonadism. Below you can see the GnRH stimulated values or cutoffs. LH FSH less than 0.3, again, this is permanent. Less than 1, this is temporary. So you need to take this very carefully because your decision will differ to treat or not to treat. Now we have the treatment of male hypogonadism. First of all, you have to treat the cause. If there is a tumor, chronic illness, malnutrition, endocrine problem, and so on. And then we have sex steroid replacement therapy, which should be individualized according to each case. What we do is that we start by a very low dose of testosterone, 50 to 75 milligrams per month, and increase gradually till reaching adult dose after 3 to 4 years. Sometimes we could start with HCG, and then 6 to 1 year later, we can add testosterone therapy in order to increase the testicular size and stimulate fertility. Another optional line of therapy is to combine HCG and HMG for 6 to 12 months and then followed by testosterone to induce spermatogenesis and fertility. Again, you have to choose. You pick and choose according to each case and the real pathology. This table shows you the forms of testosterone therapy. Of course, intramuscular is the most commonly used. It's the most popular in adolescent boys, and the rest of the types have not been studied in boys. Maybe they could be used in adults, but we do not prefer to use it in boys or in adolescents unless you cannot find the intramuscular form. Now, this is a study recently accepted this month that was conducted in Arab countries. I'm proud to be part of this study on the timing and regimen of puberty induction in children with hypogonadism. And this was a survey. Data were collected from 17 Arab countries. Here on the left side, you can see the countries that were involved. And you can also see that IM testosterone was the most popular form used in Arab countries. Here, the red arrows show you that IM testosterone was the most popular type. Here, 70% started with IM testosterone and even used it for maintenance therapy. Now, this was a very short review. Let me go to the case scenarios to apply very fast what we said. I'm going to show you the simple delay, the pathological delayed puberty, and this will demonstrate the very wide spectrum of presentations where delayed puberty was the main presentation. And the question in every case is to treat or to wait. Let's start by Yassine. Yassine is a 14-year-old boy who came with delayed puberty, Tanner stage 1. He's short, minus 2.7. His father gave history that he was short with delayed puberty, and then he catched up his height after puberty without treatment. Looking at Yassine's growth chart, he was normal at birth, and then he was a short child. And then he had more deceleration in the height and delayed puberty at the time I saw him. The boy was found to have microcytic hyperchromic anemia. His calcium is lowish. His vitamin D is insufficient. Celiac screening and thyroid functions are normal. And when we did the GnRH stimulation test, we found low FSH, low LH, and low testosterone. All are low. So help me in this. What's the type of hypogonadism? This is hypogonadotropic hypogonadism. And when we did the bone age, it was delayed. The boy is 14 years, but his bones are 10 years, and his height age is 10 years as well. So the bone age is exactly equal to the height age in an adolescent with short stature and delayed puberty. What is your diagnosis? Constitutional delay in growth and puberty. Now, what would you like to do for this boy? Here, reassure the parents he will catch up by himself. Proper nutrition, correct calcium, iron, vitamin D, and sometimes we give a very low dose of sex steroid to initiate the pubertal spurt if the boy is psychologically upset, but this is not routine in every case. Here, yes, we corrected the nutrient deficiency and we gave him nutritional support. The boy gained very nice height, as you see, normal puberty, normal final height, and he's now taller than his dad. So the conclusions here are constitutional delay in growth and puberty is a very common cause of short stature and delayed puberty. It's much more in males. A positive family history is usually present, short stature and delayed puberty, but not in every case. Patients must have delayed bone age with the bone age exactly equal to the height age, and this is the most important diagnostic point. Patients are clinically free with low FSH, LH, and testosterone, and patients reach a normal final height and puberty without treatment. Just reassure the parents and give good nutritional support. And if you need, sometimes you might give very low dose of sex steroids. Another different scenario is Iyad. Iyad is a 13-year-old boy. He was growing very well, but he developed secondary growth failure since 6 months. He's short. His weight is fine. He developed pubertal arrest. His testicular size started and stopped at 5. He developed headache, squint, attack of focal convulsion, and the mother reported a clear deterioration in his school performance. Now, this is Iyad's growth chart being normal at birth and childhood. And then, unfortunately, what happened? Here, secondary growth failure 6 months ago and pubertal arrest. Look at his curve. Thyroid functions revealed low T4, low TSH. This is central hypothyroidism. The peak growth hormone by 2 test was very low. This is growth hormone deficiency. His bone age is delayed. It looks like panhypopituitarism. And because the golden rule says whenever you have more than one pituitary defect, you should look for the rest, we did the cortisol and ACTH. Both were low. So this is central hypoadrenalism. Sodium, potassium were normal. And when we did the GnRH stimulation test, we found low FSH, LH, and testosterone. What type of hypogonadism here? Yes, this is hypogonadotropic hypogonadism. So it's definitely acquired panhypopituitarism. Putting this together, in addition to the clinical picture of the boy, what's the most urgent investigation to your mind? Yes, MRI sella tossica definitely must be urgently done in that boy. Sadly, we found low-grade astrocytoma in that boy, and the tumor was resected, hormone replacement started with radio and chemotherapy. The boy catched up his growth, puberty, and he's growing nicely and doing fine. So the conclusions here are A child who was growing well and started to have a poor growth velocity or pubertal arrest must be thoroughly investigated. Please respect secondary growth failure. There could be a serious illness, chronic illness, or tumor. Brain tumors are uncommon in children, but should be excluded in patients with panhypopituitarism. Any case of panhypopituitarism must perform MRI celatosica even if there are no neurological signs. My last case is Ahmed. He's a 16-year-old boy. He came with delayed puberty and gynecomastia. The boy is very tall, even taller than his parental height range. He has long legs, lower segment more than the upper segment. His span is more than his height. He has narrow shoulders, wide hips, truncal obesity, and a feminine contour. This is Ahmed's growth chart. He was normal since birth and childhood, and then accelerated growth occurred in childhood, as you see here. The boy is very tall for his age. The boy also had gynecomastia, Tanner 2 to 3, not tender, which is more for his age. Now, the genital examination revealed Tanner stage 1, very small testes, 3 ml, nearly atrophic, a penis being small, 3 centimeters, with no pubic hair. Thyroid functions, liver functions, alpha-fetoprotein, beta subunit of HCG, DHEAS, everything was normal. But when we did the GnRH stimulation test, we found a very high FSH and LH, low testosterone. So the problem here is in the gonad, in the testes. So what type of hypogonadism? Yes, this is hypergonadotropic hypogonadism. The estradiol was found to be very high, and there was a high estradiol to testosterone ratio, and this is the cause of feminization and gynecomastia. Now, what is the most important investigation when we have a boy with behavioral problems, hypergonadotropic hypogonadism and gynecomastia? Yes, karyotype. And this is what we found, a 47XXY karyotype. The diagnosis was Klinefelter syndrome. And the question to treat or to wait, definitely you have to treat with testosterone therapy because there is a pathology in that boy. So the conclusions here are suspect Klinefelter in boys with delayed puberty, gynecomastia, and behavioral problems. Karyotype should be done in any adolescent with hypergonadotropic hypogonadism. Testosterone therapy must be initiated in all cases because this is a permanent cause. Now, wrapping up all what we have said, remember the spectrum of our cases: constitutional delay in growth and puberty, hypogonadotropic hypogonadism, or hypergonadotropic hypogonadism. The first category, which is the most common, constitutional delay in growth and puberty, does not need treatment. And the other two require hormonal therapy. So it's very important to differentiate to go on the right track. I think this shows you how puberty is a really complex process and how hormones have got a magical effect. And to see what puberty does, I think hormones have got the effect of magic. Yes, indeed, puberty does a lot. It changes a lot in everyone. And since it's really difficult to deal with our healthy teens, what if there is a medical problem concerning the puberty? I think they could drive the parents crazy, and maybe the doctor even. It's very difficult to deal with teenagers and to play with their hormones. And so what? Delayed puberty poses a heavy psychological burden on the patient and the family even, affecting the quality of life, which is really important. And even more, it could be the key to diagnosis of a serious medical problem, like the cases I showed you. It could be a chromosomal aberration, it could be a chronic illness, it could be even a tumor, which is again even important to deal with and to diagnose. So the most important question here when facing an adolescent with delayed puberty is to ask yourself, what lies behind the wall of delayed puberty? In other words, which way shall we go? Is it the pathological puberty that needs to be treated, or is it the simple delay that does not need treatment? Don't just take the case, this is a boy who does not have secondary sexual character. It could be even more serious and deeper than this type of thinking. It could be a serious problem that needs to be solved. And thus, early diagnosis and treatment of delayed puberty helps to optimize the final height and to improve the quality of life of these boys, which is very important. And don't forget to break the wall behind delayed puberty and to ask yourself, is it pathological that needs treatment, or is it simple delay? To be able to win the challenge of diagnosing and dealing with treating such really, really difficult cases of delayed puberty. And I'm telling you this, and I love the puberty category, but really these cases are challenging and not easy to deal with. Thank you very much for your attention.
بشكر الأستاذة الجميلة رشا طريف على المحاضرة الرائعة دي كالعادة، وسعيدة جدا ان انا شفتك يا رشا، وتملي كده يا رب نتقابل على الخير يا رب يا حبيبتي. وشرفني طبعا ان انا اقدم الاستاذ الغالي العزيز الاستاذ دكتور سمير نعيم، one of the eminent professors in our department in Alexandria University, who will speak about congenital adrenal hyperplasia practical clinical approach. اتفضل يا استاذ سمير.
شكرا يا استاذ علي. Alia for the nice introduction, and thanks as well to Professor Abdesalam for the kind invitation to this respectable conference. And I'm really glad that we are going to end with real endocrinology. Now we have shifted from the endocrine pancreas to the gonads. I really enjoyed the presentation of Professor Rasha Tarif, and I will go through very interesting although it is a clinically challenging topic, the congenital adrenal hyperplasia, because it's a very good mental exercise for us clinician, physician, not only endocrinologists, but it's a very good mental exercise. And in the congenital hyperplasia, a good share between the endocrinologist and the lab important. Glad that the pediatric endocrinologist is on board with us. and there is no contradiction because adult endocrinology, we are seeing their patients, and because this is transitional endocrinology. I'm glad that I'll be hearing her comments. I will be sharing with you 4 of our cases, different phenotypes of congenital adrenal hypertension, 24 years of age, presenting with short-stage infertility. The second case he was 18 when he presented to the ER with renal failure, with severe hypertension, and he was discovered not to have a testis by the resident. The third case is a 17-year-old female presenting with primary amenorrhea with abnormal genitalia. And last is this lady who's 18 years of age with oligomenorrhea and Hirsch. When you go to the congenital, this is a nocturnal recessive. It's to defect adrenal steroids. The most are the 21 and 11 beta hydroxylase deficiency. The other one much common. Most of them being 21 and 11B, and they are common, but not rare. I'll show you maybe get our own from Egypt. I will go to the normal pathology and anatomy. So this is the associated connect and 2 tubules, the Wolffian responsible, the male genitalia, the female genitalia. Got the chromosome, i.e., are a male, the Y chromosome will stimulate the cyst to produce H, which will emit the pink genitalia, and you will get for the internal genitalia for male, and also produced by test to stimulate the external genitalia. And if you don't have a Y, by default you're going to be male, and the ovary is producing estrogen, and the inner genitalia are female. External genitalia, at the beginning, we got to differentiate the inner genitalia with the glands, penis, and body of the uterus, the folds, and labial swelling. If there is testosterone, you will get fusion of the folds, you will get normal penis, and the scrotal will need to produce we call the scrotum. And if there is testosterone, we will be adding a female inner genitalia. So the adrenal gland is remember from deer medulla, but the is called 3 layers. And most important layer today is the reticulus, because this is under control of ACTH as well. What the vesicle producing cortisol is all under the ACTH. Gonaglobulinemia is controlled, however, a little bit by the ACTH. And in the normal physiology, hypothalamus produce TRH to stimulate the TH from the pituitary to the adrenal cortex to produce the cortisol, and the sex estrogen is inactivated back. If in congenital basal defect, the steroidogenase, there is in the cortisol, so you will not have the feedback. The ending with high CRH, high ACTH, and it's very, as I will tell you now. You have to remember that mother milk is collateral for the steroid synthesis, and in the gland they can go into progesterone, hydroxysterone. Progesterone, it will end by aldosterone and cortisol. These are the main adrenal steroids. Also, don't forget about pressure. So that's 3 main roots. And when you defect in the enzymes as page, congenital adrenal hyperplasia, the anti-hypertestosterone is high. This is the whole mark for the laboratory clinical diagnosis of congenital adrenal hyperplasia. Don't be alarmed by this. You don't have to know it, but this is the cholesterol. It ends into aldosterone one way, other cortisol. Another one is the androgen, dihydrotestosterone, dihydroepiandrosterone will end to dihydrotestosterone. the first effect, most common, is 21 hydroxyl efficiency. Actually, most common have they from Egypt, but you get 1/1,000 birds from USA. Gene is located on the armor. But remember, some tigers form the carrier, and they detect it by having the stimulate, because the testosterone can be known in this case. So in 20 hydroxylase, this is the enzyme step. If you don't have it, you get stuck in this step. And having very low cortisol and very low aldosterone. So innate out aldosterone cortisol, his life is not diagnosed early because of what we call the soul-losing types, severe hyperkalemia, hypotension, and ES if not diagnosed early. But the block you in the different metabolite early to the block. You will have massive amount of aldosterone in the form of adrenal and dihydrotestosterone. And this is important because if this occurs in female neonates, you have realization of synergy. If it occurs in boy, this is good as well because premature realization, which bad as a puberty by Professor Rasha. So 21 hydroxy must come with the severe form as the told type 2/3, the blazing type 1/3, but there is more common 1 in 1,000, which we are seeing in our clinical practice, mild late onset classic with herpes and or oligonucleotide. The other forms of quadriplegia, the 11 hydroxyl much common. When you block at this, you expect the cortisol and the testosterone to be low. But at that, there is no feedback. The TRH goes up, and all the metabolic action goes 11 cortisol. DOCA. DOCA is important. DOCA, it will raise the blood pressure. They present with high blood pressure, different from the hydroxyl in the sorting type. At the same time, we get excessive action of under. So this because in again abnormal genitalia occurs severe and lean. The 13 alpha is much less common. So this site of the enzyme, if there is blood, you get low cortisol. Very low estradiol, very low hydrotestosterone they have good genital. The cortisol is very low, but low access. You get excess DOCA. That's why this patient they get hypertension. You got two forms of coronary present hypertension: 21 7 hydroxylase, the 7 hydroxylase. Remember, both 11 and 17 have tension in cause of high pressure. The last one, which is not common, I'm going back to one case, the 3BSD deficiency. So is the block, get diminution, everything, and the production of RH and ASH, excessive production of 17 antiproreglone. But look, the 15% is normal. So this is one of the pieces of using, but this is very rare. Last is the lipoid hyperplasia. Block are everything goes down to the very rare. Diagnosis of hyperplasia clinically to suspect is using neonates, hyperkalemia, hypotension, ambiguous in Italian girls, or early structure in late onset in adolescent girls. You can get girls oligonucleotide and hirsutism. Remember, the beta and 17 alpha are associated with hypertension. Let's go to our case. Shortly, case one is a 24 gentleman with shorter, and when we and him got screw swelling, the MR transverse canal, this is the and the MR, you can see there is a screw swelling, and puric that I do. Patient hyperplasia is the effect in the production of steroids. So this excessive action of CRP and ACTH, and this to hyperplasia of bones. That's what name called adrenal hyperplasia, and with excessive production of androgen. And this is the MRI of our brain, and this both glands are big. These are not normal. This is the liver, bladder, intestine. And again, let's go back to this patient. The swellings were actually adrenal rest. I mean, the testes were original rest, and there is hyperplasia, there is hyperplasia or adrenal, and you think by having that. So this compress the non-testicular tissue, leading to fertility, and lead this patient as early as possible because surgery is not very successful. And this gentleman, of course, he was normal Y genotype. We've got this 21 oxalase, excessive amount of hydroxyprogesterone diagnosed on in life, not early, excessive androgen. And of course, the cortisol and aldosterone not very severely low. He represented salt losing. Recent guideline measure one of the apart from 1900 is the one-day cortisol. In one diagnosis, I don't think that we are doing routinely here in Alexandra. For early diagnosis in child adolescent, even including the meta survey, measures hydroxyprogesterone girls in follicular phase. If it is 200 NGPL, exclude the 22 hydroxylase. If it's higher than 1,000, this 1 hydroxylase. In between, you have to do the ACTH stimulation test. And ACTH stimulation with the hydroxyprogesterone 50 program IV, and remeasure hormone 1.5 or 1, and get greater risk of plasma hydroxyprogesterone more than 500. This means that this gentleman or girl has got the congenital hyperplasia. Neonatal screening is important, and I am meeting with the people, the ministers, and I was told they are starting neonatal screening not only for research, also for hydroxyprogesterone. I don't that I will hear that from Professor Asha. And it's important to remember premature age to get a false, if you have remembered that. And in case they are worrying it, you are about the diagnosis, you have to do the ACTH stimulation. So in the lines, the Korean Society newborn screening only things due to T1. So don't you, because this is common, and correlation of the diagnosis done by ACTH stimulation. Other important tests are confirmed with such patients karyotype. Patient was AY. Prenatal diagnosis, we don't have that routinely done in Egypt. You have to university, sometimes it's, and they have to do the genome. Pelvic and genital CT bone age will, you have the bone age be this patient not will get bone age advanced, so that the beginning are tall but they are short, and this is even to remember patient who's congenital hyperplasia. Let's move second case. This gentleman was a boy coming to us in Alexandria. This was almost in early 1890s, almost 30 ago, with to the ear with renal due to severe tension, and the one exam found that he got NETs with hypospadia. So notice hypospadia. When he did the ultrasound at that time, it was a uterus, and did the typing, the available then was X. So he started the process of the gentleman, this is upper pole of kidney, and this measure the 17 hydroxyprogesterone in this boy or girl, this was 17-hydroxyprogesterone, because remember, she was a girl. The karyotype was XX, exposed to excessive androgen. That's why the genitalia was abnormal, and it was due to 11-beta-hydroxylase with excess DOCA. DOCA is very powerful hypertensive agent. In the old time, you've got the DOCA ampoule. We used to use it maybe 40 years ago to treat hypertension. It's not available anymore. So 11-beta-hydroxylase, you get hypertension with abnormal genitalia. So this is 11-beta-hydroxylase. You diagnose by measuring again 17-hydroxyprogesterone, which is the gold standard for diagnosis. 11-deoxycortisone is high. The precursors, androgen, adrenosterone particularly is high. DHEA is high. Renin, please remember, the renin is low in these cases. Why? Because there is a negative feedback of the DOCA on the renin production. So this renin is very important even in the follow-up of these cases. The third case was this young girl presenting at the age of 17 with no period, and the genitalia was abnormal. And by examining genitalia, we found actually there was rather enlargement of the glands, and you found that the urethral grooves were still open. So although she was read as a female, she was really a female also because of the XX type, but because of the excessive amount of androgen coming from the adrenal gland. So this is the CT of the lady, of the young girl. This is not a kidney, please. This is a CT, left kidney and right kidney of this girl. She was XX, but due to high exposure of the androgen, the clitoris was enlarged, clitomegaly, although she was read as a female, and she's really female again, but you have to treat her. This clitomegaly is very important for have a normal life. Again, the diagnosis of 21, you measure 17-hydroxyprogesterone, high adrenal androgen, adrenosterone. The last case was this 18 girl presenting with hirsutism and oligomenorrhea. And although she got the menarche at the age of 12, and she was an XX, but again, this is a form of 21-hydroxylase deficiency, the late onset type with excessive androgen, but later on, excessive amount of androgen. So the genitalia was normal, but developing hyperandrogenism at a later age, presenting with hirsutism, oligomenorrhea, and infertility. Again, the gold standard, when you suspect it, is 17-hydroxyprogesterone. If it is borderline, do it after ACTH. Please remember that if you suspect it as a physician, you don't need to be endocrinologist. Adrenal androgen, again, and androstenedione is very important. This is important for the treatment policy. The treatment in this case is very simple. You have to replace what is missing. This is rule number 1 in endocrinology. You have to give oral hydrocortisone, which is not very available in Alexandria. They have it. They have it in Cairo, maybe in Abu Rish. I don't know about Ain Shams. And it's not available for the open market. You have to get it from abroad, and you have to give it to correct. And you have to watch these cases not for 17-hydroxyprogesterone. You don't have to bring it down to normal. The follow-up is by measuring progesterone and measuring adrenosterone. So you have to follow these cases not by 17-hydroxyprogesterone. So this is my last message today for congenital adrenal hyperplasia. And please remember that you have got a stroke, early hypertension in life, and hirsutism, oligomenorrhea. The gold standard is to measure the 17-hydroxyprogesterone, and we have to remember that we have encouraged the neonatal screening not only for high TSH but also for congenital adrenal hyperplasia. And thank you very much for your attention.
حضراتكم. الحقيقه احنا مستمتعين بهذه الاندوكراين سيشن، وبنشكر الاستاذ الدكتور سمير نعيم على المحاضره القيمه اللي كلنا استفدنا منها. ساعات بيجي لنا في اور كلينكس عيان هايبوثايروديزم وتديله ريبليسمنت ثيرابي، ويجي لك بعد فتره بالتحاليل يوثايرويد، تقول له الحمد لله انت اتحسنت وبقيت في اليوثايرويد ستيت. يقول لك بس يا دكتور انا لسه الاعراض اللي كنت جاي بيها لحضرتك هي انا حاسس ان انا ما خفتش. انا بدعو زميلي الفاضل الاستاذ الدكتور تامر الشربيني استاذ الامراض الباطنه والغدد الصماء جامعه اسكندريه عشان يحل لنا هذه المشكله. اتفضل يا دكتور تامر.
Does tissue biomarkers have a rule for assessment of hypothyroidism? In the old days, they used to use tissue biomarkers, examples of which would be cholesterol, creatine kinase, and 6-hormone binding globulins. But nowadays, we rely on TSH. At this time, TSH were not that sensitive nor specific, and that's why they were using other tissue biomarkers. But currently, tissue biomarkers are not recommended for routine use, since tissue biomarkers are not sensitive, not specific, not available, and not standardized. This is the recommendation by the American Thyroid Association. Okay, next, would symptoms be reliable to assess hypothyroidism, whether at initial presentation or in those who are treated? In this study, this is the Colorado thyroid disease prevalence study. This was the largest thyroid prevalence study of all time. It included more than 24,000 patients. And you can see here, they have classified the patients into either having 0, 1, 2, 3, or 4 plus symptoms. If you look at the column with the 0 symptoms, you would be surprised to find that almost 30% of patients who are overtly hypothyroid, they have 0 hypothyroid symptoms. While if you look at the column for the 4 plus symptoms, you would also be surprised to find that 17% of euthyroid patients, they have 4, 5, or 6 symptoms that are classified as hypothyroid symptoms, which means that 1 in 3 overtly hypothyroid patients, they completely lack symptoms, while 1 in 5 normal persons with no hypothyroidism, they exhibit 4, 5, or 6 hypothyroid symptoms, and they have concluded that symptoms, even in newly diagnosed patients, may not reliably signal the existence of hypothyroid condition. Can hypothyroid symptoms be used in the follow-up of hypothyroid treated patients? Hypothyroid symptoms are neither sensitive nor specific. That is why the American Thyroid Association have recommended that hypothyroid symptoms are not recommended to judge adequacy of replacement therapy in absence of biochemical assessment. And that is why they have mentioned that you should consider symptoms in the context of serum TSH, comorbidities, and other potential causes of these symptoms. This was an essential introduction to our case. This is an index case of persistent or residual symptoms in hypothyroid patients. This is a 53-year-old woman presenting with 3 years history of primary hypothyroidism. She has been receiving a stable dose of levothyroxine monotherapy. She had TSH ranging from 0.5 to 2.5, well within guideline recommended range for more than 12 months. But still, at her most recent visit, she reports having continued fatigue, hair loss, cognitive difficulties that she described as brain fog. How to approach this lady's complaint? First of all, this is a common scenario. So how common you would find such a patient? So about 5% of hypothyroid treated patients would present with depression or anxiety. About 10% of hypothyroid treated patients would have impaired psychological well-being. And so it's concluded that 5 to 10% of hypothyroid patients on levothyroxine treatment, they may have persistent symptoms that can be related to the disease or the levothyroxine therapy. So I'm going to provide you with a cause-oriented approach to such a case. The first possible cause would be a wrong diagnosis. Maybe the patient is not hypothyroid in the first place, or maybe the patient is hypothyroid, but this is hypothyroidism not requiring treatment. So The first step in our approach is to confirm that there is thyroid dysfunction. You have to confirm that the patient has hypothyroidism, and this hypothyroidism requires hormone replacement. In order to do this, you have to have an access to diagnose a thyroid function test and antibodies. So if you have a patient with high TSH, low free T4, clear etiology, for example, Hashimoto thyroiditis, then this is a patient with overt hypothyroidism with a cause and should be treated. If you have a patient with TSH that is more than 10, with normal free T4, that is to say subclinical hypothyroidism, but with anti-thyroid antibodies indicating risk of progression or high cardiovascular risk, then this is a patient with subclinical hypothyroidism who is worthy of treatment. Another thing to consider is the presenting symptoms. If there was an initial response to levothyroxine therapy that was subsequently lost, or maybe the patient never responded as regards to the symptoms. So about the possibility of wrong diagnosis, you may think of wrong diagnosis in this scenario: high TSH, normal free T4, with no anti-thyroid antibodies indicating progression, no high cardiovascular risk. Actually, this combination can be explained by other causes other than hypothyroidism. Obesity can do this. Non-thyroidal illness syndrome during recovery can cause this, and even adrenal insufficiency can be associated with moderately or even severely elevated TSH that's corrected on replacement. So maybe the patient was not hypothyroid in the first place. So you have to confirm that the patient has other diagnoses, and so instead of treating the original diagnosis, you are treating the wrong one. The second possible cause to explain the patient's symptoms may be the patient is inadequately treated with levothyroxine, or maybe the patient is not achieving the TSH target, or maybe she is having fluctuation of TSH from visit to visit. Actually, physicians are not doing a perfect job. Here you can see the prevalence of TSH that is out of range for hypothyroid patients treated for levothyroxine, even for long years. So you can see here that we have a high percentage of patients on levothyroxine that have serum TSH above the reference range, indicating under replacement or indicating hypothyroidism. Even those who are being replaced for many years, actually this ranges from only 11% and up to 42% of the treated patients. So there is a good possibility that you have this patient actually not achieving target. And so for this step, you have to ensure the adequacy of levothyroxine dose. As mentioned before, most guidelines recommend returning serum TSH to the population reference range. Not only the reference range, but if you remember, the European Thyroid Association recommended the lower half of the reference range, that is from 0.4 to 2.5, and the Italian Endocrine Society recommended from 1 to 3, that is the lower half also of the reference range and not the lab reference range. And so you have to confirm that your patient is fulfilling two conditions. They are meeting these targets, number 2, for several occasions, and number 3, for a period ranging from 6 to 12 months. If your patient doesn't have these criteria, you should achieve this target. A third explanation for the patient's symptoms would be obesity. We know that obesity commonly associates hypothyroidism. They are not improved by achieving euthyroidism. You can see here that Polk and colleagues found that obesity correlated with poor quality of life in hypothyroid patients, even after achieving euthyroidism for 6 months. Quality of life subscales as those impaired in their cohort. Their cohort were hypothyroid patients on replacement therapy for at least 6 months. So the third step in our approach is to screen for obesity and manage appropriately. A fourth explanation would be psychological stress, or maybe having psychological comorbidity like depression and anxiety. Actually, awareness of having chronic illness may have a burden for the patient. So awareness of having a chronic disease, awareness of having to depend on thyroid hormone medication for the rest of the life, awareness of the necessity of regular medical visits, they may actually cause discomfort, unwellness, unhappiness, and feeling less healthy. So the fourth step is to screen for psychological comorbidities, namely anxiety and depression. Psychological comorbidities may confuse the diagnosis because depressive symptoms look like hypothyroid symptoms. Subjects with depression may be more likely to be screened, diagnosed, and so triggers who are dissatisfied with the general condition of their health will be overrepresented in patients with receiving levothyroxine, and so automatically any persistent complaints would be wrongly attributed to levothyroxine. Furthermore, in patients who suffer from anxiety, the addition of T3 may affect the response of the treatment of anxiety, and in some patients, they may even worsen the condition of anxiety. The fifth explanation is having physical comorbidity. This physical comorbidity may be autoimmune or non-autoimmune. So it is well known that hypothyroidism, most hypothyroid patients are caused either by Hashimoto thyroiditis or thyroid ablation for Graves' disease. It is well known also that autoimmune thyroid disease is associated with other autoimmune diseases. So about 10% of Graves' disease and 14% of Hashimoto thyroiditis, they are associated with other autoimmune diseases, the most common of which would be rheumatoid arthritis, present in 3% of Graves' disease and 4% of Hashimoto disease. Patients with autoimmune thyroid disease have 10 times the relative risk of having pernicious anemia, systemic lupus erythematosus, Addison's disease, celiac disease, and vitiligo. That's why screening for other autoimmune diseases has been recommended in patients with autoimmune thyroid disease presented with new or non-specific symptoms. Actually, continual attribution of the symptoms to a hypothyroid state in spite of achieving normal TSH may not only result in the misdiagnosis of potentially serious conditions, it may also lead to serious exacerbation of the symptoms, and it may pose a threat to life. For example, if this may actually precipitate a dystonia crisis. So, the fifth step in our approach is to exclude physical comorbidities. Given the non-specific nature of hypothyroid symptoms, the symptoms may be caused by another condition or maybe two coexisting conditions, and this gives the symptoms because of the high prevalence of hypothyroidism in the general population. So you have to consider other comorbidities by taking careful history taking, by examination, and by investigations. What are the other? Adrenal insufficiency, hypogonadism, other autoimmune diseases like celiac disease, pernicious anemia, or systemic lupus, nutritional deficiency, vitamin D deficiency, vitamin B12 deficiency, or folate deficiency, non-specific syndromes like chronic fatigue syndrome, fibromyalgia, or polymyalgia rheumatica. Some drugs may give hypothyroid-like symptoms. Beta blockers may cause bradycardia. Statins may cause myalgia. Even over-the-counter herb pills and supplements may be the cause of hypothyroid-like symptoms. And maybe it is an abnormal lifestyle like sleep deprivation or obstructive sleep apnea or work-related exhaustion or stressful life conditions. And the latest list of possible causes may include chronic liver disease, chronic kidney disease, or congestive heart failure. And so actually we have a long list of exclusions, and the first step of our approach consists of screening for such comorbidities, but maybe by ordering these list of investigations: cortisol, AM, testosterone, fasting plasma glucose, hemoglobin A1C, CBC, anti-nuclear antibodies, ESR, vitamin D levels, albumin and prothrombin, creatinine, and albumin-creatinine ratio. The sixth possible explanation for the symptoms of the patient would be thyroid autoimmunity per se. In this study, they found that patients with euthyroid Hashimoto thyroiditis, they suffered more from fatigue, dry hair, easy fatigue, dysphagia, chronic irritability, and nervousness compared to patients who are not Hashimoto thyroiditis with benign thyroid disease. In a second study, they found that TBO antibodies correlate with psychological stress, intensity of symptoms, number of reported hypothyroid symptoms, and it predicted poor psychological well-being using symptom checklist 90. Also, high TBO and TG antibodies, they were found to correlate with lower quality of life scores and lower domain scores using SF36. In a fourth study, they found that TG antibodies, but not TBO antibodies, they have positive correlation with the number of reported symptoms, including fragile hair, face edema, eye edema, and harsh voice. As regards our experience in Alexandria University, we have conducted this study. We have included 124 patients with Hashimoto thyroiditis who have been euthyroid for 6 months, compared to 70 patients with euthyroid, benign thyroid disease other than Hashimoto thyroiditis. They were both euthyroid and they were both have comparable TSH levels. We have used Thypro questionnaire. Thypro questionnaire is a quality of life questionnaire that is thyroid specific, which is better than using SCL90 and SF36, which are generic questionnaires. They are not thyroid specific. And we found that Hashimoto group showed significantly higher score in hypothyroid symptom scales, in spite of achieving euthyroidism for at least 6 months. And within the hypothyroid symptom score, we found that the significant difference related to dry skin and swollen hands and feet. What is the explanation for thyroid autoimmunity causing symptoms? These may be some of the explanations. Thyroglobulin receptors were found to be expressed in brain and skin with unknown function. TBO and TG antibodies were found in the CSF of patients with Hashimoto encephalopathy. TBO antibodies were even found to bind human brain astrocytes. These antibodies may be causing vasculitis, cerebral hypoperfusion, and they may decrease gray matter density. The last explanation for our patient would be inadequate levothyroxine treatment modality. A little bit of physiology: the thyroid secretes only 5 micrograms per day of T3, but 90 micrograms per day of T4. T4 then converted using deiodinase 1 and deiodinase 2, giving about 25 micrograms per day of T3. So the total daily output of T3 would be 30 micrograms, only 5 micrograms is by direct secretion, and 25 micrograms per day is by conversion from T4. And then the T4 is actually distributed only 25% within the plasma, but 75% of the T3 content is within the tissues. It is the T3 that goes into the nucleus and binds to the thyroid hormone, thyroid receptors, and causes the neurocognition effects. So this bit of physiology may suggest that T3 is more appropriate to use for replacement than T4. This led to a number of studies that have tried to compare combining T3 and T4 versus giving T4, which is the standard of care in the current era. You can see here that 16 studies have been conducted. They have compared quality of life, mood, cognitive outcomes, and patient preference for treatment with a combination of LT4, LT3 versus using thyroxine monotherapy. The results were distributed as you can see. 4 studies reported improvements in quality of life, mood, or cognition. 2 noted that patients preferred more the combination than the monotherapy. However, the remaining 10 studies, they were neutral. They found no advantage for either monotherapy or the combination. 4 systematic reviews tried to clear the cloud, and we are going to review the results. A first systematic review of 9 trials, they found no benefit in the mood, quality of life, or psychometric performance to the combination. Another meta-analysis of 11 trials also found no differences in pain, depression, anxiety, fatigue, cognitive function, or quality of life in favor of the combination. A third meta-analysis of 9 trials found no significant difference in the studies that measured the preference. People preferred the combination rather than the monotherapy. And one last meta-analysis of 10 randomized trials, they found sporadic, inconsistent improvements associated with the combination regarding mood and cognitive function and quality of life. However, by the end of the analysis, there was no difference in patients' preference between treatment. For the 16 studies and the 4 meta-analyses, the overall conclusion that there is no reproducible clinical evidence to support the efficacy of combination of T4 and T3 over monotherapy with levothyroxine. So the last step in our approach is to consider a trial of this trial only in patients who are compliant to levothyroxine and have normal TSH but persistent complaints. Patients have already received psychological support to deal with the chronic nature of hypothyroidism. Associated autoimmune non-thyroid diseases, whether physical or psychological, have been ruled out. Only those who specifically requested, only those who fully understand and accept, even with written and documented information, the unknown potential for long-term harm, and definitely endocrinologists are the only ones entitled to give this trial. Do not use T3 combination in following patients. Patients with significant cardiovascular disease or arrhythmia. It is not recommended in pregnant women or women actively trying to conceive. It is not recommended in elderly patients. It is not recommended in patients with poorly controlled anxiety, and it is not recommended in patients with thyroid cancer requiring suppression of serum TSH. To conclude, 5 to 10% of hypothyroid, well-replaced patients would still complain. Possible causes include disease awareness, obesity, thyroid autoimmunity, associated autoimmune disease, psychiatric illness may be the cause. I have shown you a 6-step approach that I have suggested. The first step is to confirm hypothyroidism diagnosis and to confirm levothyroxine requirement, to confirm adequacy of levothyroxine replacement dose, screen for obesity and manage appropriately, exclude physical comorbidity, consider the combination of T3 and T4, and on a trial basis. Finally, T3 lacks evidence to support its routine use, and thank you for listening.
برزنتيشن. انا كنت عايز اخد راي حضرتك في بيبر انا قريتها في ناس كانوا هاشيموتو ثايرويدايتس وخدوا ريبليسمنت ثيرابي وكانوا ستيل بريزيستنت للسيمتومز، وقسموهم لمجموعتين، مجموعه استمرت على التريتمنت وهم يو ثايرويد ستيت، وناس عملوا ثايرويدكتومي. لا، الناس اللي عملوا ثايرويدكتومي السيمتوم دي بقت ريليفد وفسروها ان هم شالوا الانتيجينيك تيشو. فعايز اخد راي حضراتكم.
بصي، هو دي الترايل الوحيده دي واللي عملوها كانوا جراحين، فيعني
عايزين نمشي.
انا I do expect bias، يعني I do expect bias لانها هي الوحيده دي. هو القصه كلها انه في كونتراديكشن كبير ما بين الايفكت اوف ليفوثايروكسين ريبليسمنت على السنتر. ففي a number of trials بيقولوا ان الليفوثايروكسين بيدي امبروفمنت كويس، في a number of trials بيقول انه ما بيحصلش فيه امبروفمنت. ممكن يكون السبب يعني في الاختلاف هو الديفرنت ثيولوجي، لانه زي ما انا قلت لحضرتك انا كنت عملت سايتيشن لبيبر احنا عملناه عندنا في الكليه. احنا قارنا ما بين اللي عندهم هاشيموتو وخدوا ريبليسمنت وكانوا اتشيفنج ايوثايروديزم لمده 6 شهور، قصاد ناس يا اما كان عندهم ايوثايرويد بيناين ثايرويد ديزيز، يا اما كان عندهم هايبوثايروديزم بس لاسباب اخرى سواء كانت ثايرويدكتومي او راديو اكتيف ايودين ابليشن، برضه كانوا اون ريبليسمنت وبرضه كانوا ايوثايرويد وبرضه كان بقى لهم 6 شهور او اكثر كنترول. والحقيقه احنا لقينا في فرق بيزد اون ايتيولوجي، يعني كان في فرق في الهاشيموتو فيرسس اللي ما عندهمش هاشيموتو، وكان الفرق في الهايبوثايرويد سيمبتوم سكور. يعني السكور اللي احنا استخدمناه اسمه سايتو، ده كان فيه 13 سكيل، في منه الهايبرثايرويد سيمبتومز والهايبوثايرويد سيمبتومز والكمبريشن سيمبتومز وانزايتي سيمبتومز، يعني 13 سكيل كاملين كانوا كلهم كومباربل، لكن كان في فرق في الهايبوثايرويد سيمبتوم سكيل، وده اللي بيسجست انه ممكن يكون الاوتو اميونيتي نفسها هي السبب. واللي بيسبورت الموضوع ده اكتر الانتيتي اوف هاشيموتو انكفالوباثي. عارف انه يعني هاشيموتو انكفالوباثي موجود من الستينات، اول حاله اتوصفت في 66، والاكسبلانيشن اللي موجود لحد دلوقتي ان الاوتو اميونيتي هي اللي بتسبب السيمبتومز، فممكن تكون الاوتو اميونيتي هي اللي يكون لها علاقه بالسيمبتوم بيرد. لكن نفس الكوهورت دي يعني اللي انا قلت لحضرتك عليهم دول كانوا 194 عيان، قسمناهم الحقيقه بطريقه ثانيه، وكان الغرض ان احنا نشوف الناس دول كان عندهم ايوثايروديزم، وكان قصادهم حوالي 90 عيان كانوا ايوثايرويد بس without treatment، يعني عندهم ثايرويد نوديول بس ايوثايرويد، عندهم هاشيموتو ثايرويدايتس بس كانوا ايوثايرويد، يعني ايوثايرويد with treatment او ايوثايرويد without treatment. والحقيقه لقينا ان اللي بياخدوا ليفوثايروكسين كانوا السيمبتوم سكورز عندهم احسن، بالذات في الدبريشن والديلي فانكشنينج. فيعني الحقيقه في كونتروفيرسي كبير، الليفوثايروكسين بيحسن السيمبتومز فعلا ولا لا؟ ممكن الموضوع يكون له علاقه بالايتيولوجي، ممكن يكون الموضوع له علاقه بالديجري اوف هايبوثايروديزم ات ذا ستارت اوف تريتمنت. يعني كتير من الستاديز بالذات اللي بيبقى فيها سب كلينيكال بيبقى فيها كونتروفيرسي، لكن لما العيان بيبقى ديبلي هايبوثايرويد ويبدا علاج ديفينتلي السيمبتوم سكور بيبقى احسن. لكن الحقيقه انا الاستادي اللي حضرتك بتقول عليها ديت كانت من ضمن الحاجات اللي يعني الواحد كان مطلعها في الليتريتشر ريفيو، ولقيتها وحيده ومفيش حاجه تسبورت النوشن ده، فانا الحقيقه اي ديد نوت سايت، والحقيقه مش مقتنع الحقيقه بنتائجها.
تمام، شكرا دكتور تامر على التوضيح.
لما تلاقي الموضوع فيهم جراحين يعني يبقى يعني سسبكت ان الموضوع له غرض اخر يعني.
ماشي يا بيه. استاذ سمير بيه في سؤالين لحضرتك يا بيه.
اتفضل.
الدكتوره مروه صلاح بتشكر حضرتك طبعا على الاليجنت برزنتيشن، بتقول لحضرتك لو كونجنتال ادرينال هايبربليزيا فيميل بيشنت وجيتنج ماريد وكونسيرند بالفيرتيليتي، الريكومنديشن بتاعت حضرتك ايه؟ والمانجمنت ديورنج بريجنسي ايه؟
هو سؤال جميل جدا طبعا استاذه مروه، انا يشرفني ان انا اكون معاكي في التيم بتاع الاندوكرينولوجي في اسكندريه. يمكن الجايد لاينز قالتها دي كليرلي ان الومن في الشايلد بيرنج بيريود لو هو اوريدي ايرلي اون طبعا لازم هياخدوا هيدروكورتيزون يكملوا ليتر اون. احنا في مصر عندنا زي ما قلت لك الاورال مش موجود، لكن we can give prednisone and prednisolone and continue it during pregnancy, but not dexamethasone. Dexamethasone is contraindicated in pregnancy because dexamethasone is not metabolized as the placenta, while others, the hydrocortisone and prednisolone, are metabolized, so are they controllable, but not dexamethasone. And if you got the late onset or the non-classic type and the female is not fertile, you can start glucocorticoids, as I did mention, either hydrocortisone and or prednisone, prednisolone, but not dexamethasone during pregnancy. And you have to watch the androstenedione, not the 17-hydroxyprogesterone. And if she's wanting to get pregnant, you have to be sure that the serum progesterone is less than 0.6 nanogram per ml during the follicular period, to be sure that she's really good suppressed before pregnancy.
سؤال تاني واخير لحضرتك برضه يا دكتور سمير، من زميلنا الدكتور مصطفى بكري، ده مدرس سكر واندوكراين عندنا في المنوفيه، زميلي العزيز. بيقول لحضرتك لو في فيميل بيشنت عندها مايلد اليفيشن في ال 17 هيدروكسي بروجسترون بس مش واصله للدايجنوستيك ليفل، وعندها مايلد هيرسوتيزم وابنورمال منستريشن، ايه البيست بروتوكول ليها دي؟
Dr. Mustafa, thank you very much. I'm really glad to hear from you. Dr. Mustafa, in the old time, we had a nomenclature called adrenal hyperandrogenism, which sometimes are really used because you don't have a classic congenital adrenal hyperplasia. I mean, non-classic, but with 17-hydroxyprogesterone more than than 500, and even after the SSTH stimulation. So I think you are alluding to that patient with hirsutism and plasma hydroxyprogesterone, even after SSTH, is not more than 500 milligram. In this case, we used to do what we call the dexamethasone suppression test. And I think, to me, this is clinically important. We give 0.5 milligram, I mean 1 tablet dexamethasone, morning and evening for 5 days. And we remeasure the serum testosterone. If the serum testosterone is suppressed more than 50% of the baseline, means that this is conferring the adrenal origin. So this patient can benefit from being given steroid, namely dexamethasone, to improve her symptoms. What we call the dexamethasone suppression test, which is similar but different from the dexamethasone suppression test for Cushing, if you suspect adrenal hyperandrogenism. And I usually do it. And also in adrenal hyperandrogenism, beware of prolactin, because prolactin is a potent stimulant for the adrenal androgen. And this is, we don't teach that to our students. And even mild hyperkalemia, not causing galactorrhea, can induce adrenal androgen. So in my cases, usually I give them cabergoline in addition to dexamethasone in these cases with mild form of congenital adrenal hyperplasia. Thank you.
احنا بنوصل لنهايه السيشن، كانت سيشن ممتعه بوجود حضراتكم، الاستاذ الدكتور سمير نعيم،
انا بشكرك الدكتور محمد، وبشكر الدكتور علاء تاني، الاستاذ علاء، الاستاذ تامر، والاستاذ رشا.
ليه شرفتونا والدكتوره رشا شرفتنا، يعني حقيقي سيشن ممتعه، والدكتور تامر الشربيني بنشكركم وبنقفل السيشن.
حضراتكم كانت سيشن رائعه الحقيقه.
بوجودكم والمعلومات القيمه اللي كلنا استفدنا منها حقيقه يا دكتوره رشا. شكرا.
نشكر حضراتكم
جميعا.
شكرا لحضراتكم.